Hi, everybody. Good evening in Europe, and whatever other time zone you're in, it's good morning or good afternoon. Welcome to the UEFA Medical webinar of this month. I'm Evert Verhagen, and today we're tackling one of the most important and maybe rapidly evolving topics in our field, which is brain health in football. This is not a single conversation. It spans, I think, decades of players' life, from the grassroots pitch where a 10-year-old heads a ball for the first time to the elite match environment where our on-pitch decisions matter enormously, and all the way to the living room of a retired player in their 50s wondering what years of heading might mean for them now. So it's not an easy topic. At UEFA, we've built a structured approach around three pillars. We want to protect the developing player, support the current player, and look after the retired player. And today we're going to walk through all three of these with two outstanding guests who've been at the center of this work with us at UEFA. But before I introduce them, I want to quickly ask on the stage our Chief Medical Officer, Zoran Bakhtiarovic, who wants to say a few words about the topic.
Thank you, Everett. Good evening or good morning from Seattle to everybody. Good evening, Europe. Just wanted to say today's topic is extremely important and very close to my heart. We at UEFA take the head injuries very seriously. As all of you may know, a couple of years ago we went out with the heading guidelines for the youth. We are currently running or assisting run the Erasmus Plus grant of European Union called Reform. Very advanced project in which we will develop the educational tools for the youth players, parents, coaches about understanding, recognition, and respecting the concussion. We were not happy with this, so we are going out, or we already went out, but going out publicly with the heading guidelines for youth coaches. This will be part of the topic today. For the active players and actually for the doctors that are on pitch and not seeing concussion every day, we came out with so-called concussion cards, which is basically on-pitch concussion assessment tool that has been developed by the experts, not scientifically experts who are seeing a lot of concussions, not scientifically validated, but they are there to assist doctors who don't see concussion on a daily basis, how to best use 3 minutes on pitch. I want to compliment FIFA on their great work in this area as well, especially with our concussion campaign and the Focus, which is a study in which in which we are heavily involved as well. FIFA is trying to establish scientifically validated tool for the on-pitch assessment. Our tool is not by any means competition to it. It's more complementary because FIFA 1 is more for the elite levels of the football, and FIFA competitions, ours will still remain active and modifiable, I would say. Claus will speak about it a bit later for other levels. And finally, we are also working, and stay tuned. Soon we will go out with the tool for the overall health and protection of the brain health of all levels of football, not only for football, especially for the retired football players, but not only for them as well. But stay tuned for that. And I want to say something that I'm extremely proud of. It went a little bit on the radar for those who don't know. All of this that we are doing obviously is not good if we don't have regulations to support it. We do have regulations to support it, the UEFA medical regulations. We have a concussion charter. And I'm very proud that some 2 weeks ago, one club and one coach were fined seriously for not disrespecting the call of the club doctor. So club doctor evaluated the player, suggested the replacement or substitution. Coach and the player disregarded. The result was that the club was fined 20,000 euros for sending wrong message about UEFA competitions, 10,000 for disrespect of concussion charter. Coach was personally fined 20,000 for disrespect of concussion charter, and whole club must provide evidence to the UEFA that they have undergone the concussion education for all coaches and players. I think this is a major step forward in what we are doing, But just to tell you all who are listening us, we at UEFA Medical and Anti-Doping are supporting you. Now I'm heading floor back to Evet to introduce our very exciting two speakers today.
Thank you, Zoran, for those words. Good highlight of what we're doing and what we're trying to achieve at UEFA on this topic. So before I introduce our speakers, just to remind you, in the comments section, you can always post your questions where we are in the discussion, and I will try to weave your questions and your comments into our talk today. So without further ado, I want to introduce Claus Reinsberger and Edwin Goedhart to the stage. Claus, welcome. Starting with you, maybe you can introduce yourself briefly and tell us what you're doing at this area.
All right, thank you so much, Evert, Zoran, for inviting us to the webinar and also giving us a chance to contribute to the work of this very, very topic at UEFA. I'm Claus Reinsberger. I'm a neurologist. I am a professor of sports medicine at Paderborn University, and I'm directing the sports medicine program there. And I'm also the director of the Division of Sports Neurology and Neurosciences at Mass General Brigham at Harvard Medical School, implementing a more focused program on sports neurology and neurosciences there as well.
Great. Welcome, Claus. Edwin, same question to you. Can you briefly introduce yourself?
Yes, and also thank you for the invitation. But it's my name is Edwin Goedhart, and I'm a sports medicine physician. And since more than 30 years, I'm a team physician in professional football. Now, since 2013, I am the chief medical officer of our National Football Association. And my interest for this specific area in sports medicine lays in the background that when we started 30 years ago, then we only had two questions. And it was, how are you? And can you continue when somebody had a head injury? And I felt it was a little bit soft, to make all the kind of the good decisions. We should have done better. And I think we've achieved a lot since 30 years. And also brain health is we adopted it as a topic at our National Medical Center, and also for practice-driven research for concussion, but also for heading. So that's my link with this subject.
Cool. Good to have you both here as a leading scientific clinical expert and a leading practical expert as well. So let's start where football starts, with young players. There's been an enormous public and regulatory interest recently in heading restrictions for children. As far as I know, England, Scotland, the US have introduced specific rules. Parents are worried, coaches are uncertain. But where does the evidence currently sit in regard to heading in youth football? Can you elucidate a little bit more on that?
Very happy to, unless you want to, Edwin.
No, Claus. It's scientific. It's your domain.
How much time do we have?
We have 1 hour, so let's keep this a bit brief.
Not just for that topic, because I think that is probably the most difficult one to start with, because the evidence is very, very mixed. I mean, on the one hand, you can say the less you stimulate the brain in a negative way, the less negative consequences you have to fear. On the other hand, we have also learned over the years that we cannot be short-sighted and just believe that we solve problems by restriction, because we have to think ahead, and we have to also accept the very complex task of heading the ball as a very, very important part of the game. And if we don't teach children how to head the ball correctly, which is, as I said, a very, very difficult motor program and a very difficult task, we may run into even bigger problems afterwards. So the first important thing that I would like to mention in this topic, because I've seen this mixed up very, very often, is if we talk about heading, we're not talking about acute brain injuries or acute concussions. These are two different things. So when we look at heading the ball, we look at potentially negative aspects or potentially negative effects of repetitive head impacts, which are what we believe are minor. And we know also from other collision sports, not only contact sports, collision sports, that cumulative repetitive head impact can be meaningful and can be have the potential to be meaningful and possibly influence short and long-term health. So it's certainly a topic that we have to look into very, very deeply. If we look into the countries where, for example, simple header bans for certain age groups have been implemented, we don't see data that this had an immediate effect on both short and midterm health. And that's why, and maybe I should speak about a little bit, or I can speak about a little bit to the situation in Germany that we took, where we thought, okay, well, we have to go in a different approach, and we decided to go in a more differentiated approach and took the UEFA guidelines and worked with the UEFA guidelines with our coaches, because our intention was to not tell people what not to do, but rather tell people what to do to the best of our knowledge, with reflecting all the evidence. And by the way, this paper is currently under review. We submitted this concept as a scientific paper because it is quite different from other concepts that have been published. Over a span of 2 years, Tim Meyer and I were meeting with a bunch of coaches in Germany and in German football, and we came with, or we proposed a couple of measures and interventions of how to train and how to teach young kids, middle-aged kids, and adolescents the complex task of heading the ball with the least impact possible, and therefore hopefully the least negative consequences that heading the ball or repetitively heading the ball might have. I think it's a little bit too much right now to discuss details of the program, which is going to be published soon and going to be hopefully circling back to UEFA at some point. But the basic idea is really kids need to learn how to safely head the ball without exposing themselves to too much impact and too much repetitive impact. And I might say that there's no evidence for this approach, but we hope to gain evidence by implementing this approach, because we believe that it rather reflects the interpretation of the of all the data we have in the literature more thoroughly.
Yeah, thank you for that elaborate explanation, Klaus. And anything to add, Edwin, on the scientific side?
What we thought, in the past was that was also my position, is that if there are some negative effects of heading, then we should stop heading, because that's not what we want. Now we are a little bit further also with our researchers and also our conclusion, our thoughts. And I have a different opinion now, because I think that in some cases heading could be even more protective than not heading. And so there are solutions that it's good to head, just to protect the brain or the head for that purpose. So I think that there's no way that we should ban heading, but perhaps when you have a dose response reaction before, you should look at how many headers there or headings there are, how intense they are, the impact they have. So we should not go for the simple solution, which is a ban heading, but we will go for the best solution. And that means that you have to go a little bit deeper in these materials and say, well, what can we learn from other situations, but also to have a proper technique. And don't forget that also having a good technique of heading in one way or another also protects more or less. It's a bit awkward, but it protects you also against concussions, I think. Girls and women are more affected by concussions by hit by the ball than, for example, boys and men, but they are better headers also. So there's something to learn from that perspective, and also to improve the technique, like Klaus already mentioned.
Yeah. And just to add to that framework, Klaus, that you just introduced, we adopted that one, and we will starting filming soon for an educational video for coaches. So that's good. Can you briefly talk us through, the 4 key areas in there? It's age, technique, load, those little things. Can you briefly elucidate on the contents, Klaus?
Edwin, I'm sorry. I think I have lost you for a second. Can you repeat that question?
Oh, okay. The question is the heading framework for youth. It's based on 4 pillars. It's an age-graded approach, technique approach, a load volume approach, and the coach's role. Can you briefly elucidate on the core concepts of the framework?
Yes, as you said, there are 4 approaches. I mean, we even try to call it 11 for the head, and we came up with more or less 11 simple instructions of what to do. So a couple of things are geared towards the reduction of brain impact. For example, applying of regular training of headers should be low and only slowly progressing without focusing on many repetitions. There should be attention to the relation paid between passing and throwing, the distance and the number of repetitions. The impact should be reduced. For example, lighter balls, maybe even lower ball pressure should be applied in certain circumstances. External circumstances should also be recognized. So, for example, if there's cold and wet weather conditions, header training should be reduced, and header training should always be accompanied by regular athletic training, for example, to strengthen the neck and the shoulder muscles. And then also emphasis should be paid towards recovery. So if you train headers, you should not train headers 3 consecutive training sessions in a row, for example. You should ensure sufficient breaks between the training sessions, support recovery measures, which is very important. Sleep has been identified as one of those factors that actually help recovering from this type of stimulation. And then also emphasis should be paid on the heading technique. So technique should be trained under controlled circumstances, especially in terms of avoidance of collisions. And then finally also, and this is where the coach is very, very important, people should be sensitive and sensitized for concussion symptoms. So for example, coaches are encouraged to collect feedback from players after heading training about the perception of the stimulus that was applied and possible occurrence of symptoms like neck pain, headaches, dizziness, or other symptoms, and then engage in a longer break, and also encourage self-analysis and feedback. And then finally, talking about the coaches, they should also recognize that some players had the ball more frequently than others. So those techniques should be applied, especially focused on the players who have lots of headaches, whereas other players may not need to engage in all of these training interventions so regularly.
Yeah, so it's quite an elaborate framework, and I think we summarized it well in a briefer document that will be released soon for everybody to use. But I think you highlighted a key issue in your answer that I want to pick Edwin's brain on. It's for coaches. So we need to convince coaches to change their practice. Edwin, from your experience, because we're talking to medical staff here now on the call. When medical staff is trying to influence training practices around heading, what resistance did you meet, or do they meet in general, and what is a good way to navigate that in this instance?
Ooh, that's a difficult question, Evert. Yes, of course you will meet some kind of a resistance because you're changing something in the culture. That's one thing. Secondly, they think, or at least the majority of coaches think that medical staff shouldn't interfere with training sessions anyway. You know, that's for them and their experience. But it's no, I think it's at the end, you know, mentioning that it's about players' health and stress it again over again and again. I think that would be something, and that it's something important, and that it's. But you need backup from your national association, so that's something that they need to support you as well. So it goes from top down, more or less. But I think it's try to explain the easiest things. You know, it's like one of the advices that we've given is just, you know, the day after the match, for example, or the 2 days after the match, you know, avoid heading. There are still some coaches that think that heading the ball as a kind of play. We call it foot volley, but there's also the possibility to head a lot. And I think it's a very good exercise to relax the day after the match. That's something you have to change. Not only because perhaps the impact might still be low, but it's about the image. If we tell everybody that you should avoid heading the first 2 days after a match, then you should do it also in these kind of small exercises. But it means that you have to explain it again. And my experience, you won't make it in one time. You have to do it several times and explain it again and over again. Changing cultures will not go easily. You have to explain over and over again, and sometimes it frustrates you a little bit, but keep it continuously active. So and try to explain it. But I think also for us and also for UEFA and FIFA, but for all those organizations, and also in national associations, they have to also give you some backup and support, and also give the information that you can use to convince the coaches to change their attitudes. And still, I think in some countries it's a big issue at the moment. So they cannot tell you that they didn't know or that it's not an issue. It's a big issue, and everything that can help you decrease the emotional input in these discussions would be very helpful, and that also implies having a good strategy on heading.
Yeah, it's not easy. Change behavior. My answer usually is doing something is better than doing nothing. You can't change the whole world by yourself, but if everybody does a little bit, usually you get far.
That's right, Edwin, and don't expect it to don't expect an effect immediately, but if you have it in 1 or 2 seasons, then you've done a great job.
Yeah. So hopefully the materials we're developing at the moment together with the DFB, based on what Claus just explained as well, are a helpful tool for everybody, and is helpful in changing coaches' mindsets and actual football practice with youth players. Given time, we can talk another hour on this, and maybe we should have a full new webinar on this specific topic. But let's move on. Move on to the adult player and the match environment. Let's talk general players, not professional elite players, but just general players. A player takes a blow to the head, the clock is ticking, the manager's watching, the crowd reacts. What actually needs to happen in that first bit, let's say 90 seconds, 2 minutes, and how well do you think medical teams currently are equipped to react to that situation proficiently? Open question to both of you, whoever goes first.
Evert, as you know, we can also ask, what does the science know about these first 2 minutes? And there's very limited amount of data. That doesn't mean, picking up what Edwin just said and what you just said, that doesn't mean that we shouldn't do anything, but we thought we have to do something, because if we look at the acute concussion, I think if somebody has a diagnosed concussion, we have advanced tremendously in treating the concussion afterwards. We have changed our paradigm completely, what to do after a concussion, I would say, in the past 10 years. And this was largely driven by data. So now if we focus on the situation that you just described, which is the on-pitch situation, where the primary goal is to recognize and remove, the recognition part needs to be probably improved. And the recognition part on grassroots, for example, is by really spreading the knowledge, sensitize people, or making people more sensitive to symptoms and things like that. And then the even more, maybe even the more problematic situation is on the pitch, where millions of people are watching and everybody knows it better, and everybody sees like camera views, but not the person who actually makes the decision, which is the doctor. So this is where we actually got a lot of feedback and a lot of questions from the doctors when we started in Germany, for example, but also across our project, looking into the question, what is actually happening at UEFA games over the past 3 years, where people were saying, well, we don't really know what to do. And because mostly people who are on the pitch, like Edwin and others, do not see concussion on a regular basis in the clinic or even on the pitch, because at the end of the day, we still have to consider that football, like regular football, international football, is not a high risk sport for concussion. It's a contact sport, but not a collision sport. So we don't see that very, very often. There are good numbers in several leagues across the world, and it's not a very frequently encountered injury. But a head clash or a head contact is something that we see very often. So now we have to come up with something that is helping us and helping everybody on pitch who doesn't have a lot of experience with recognizing or even treating concussion, to really detect every concussion, to make an appropriate decision in terms of removal, substitution, or not. And
I wanna ask a completely different question, but it started in the first sentence. No, it's fine. No, it's fine. There's also a question in the chat. I want to go to that one in a second. But first, Claus, you mentioned now already twice, also when we started with the youth, there's limited evidence on these topics. But what do you mean exactly with limited? There is no studies being done. There's conflicting evidence. There's not enough quality evidence, because there's a lot of headlines and there's a lot of gut feeling. But what do we mean with there's limited evidence?
There's a lot of headlines and there's a lot of gut feelings, but there's limited amount of data for the situations that we're discussing, because concussion is not always the same. And then there are, I can tell you that from my own experience working in two parts of the world. One is in Europe and one is in North America, and the medical system is completely differently organized. The sports is completely different organized, and although we're talking about the very same type of injury, also how injuries are worked up and how algorithms are composed and applied might be very, very different. And I wasn't aware of this difference before I really took part in both of these systems. So we have to be careful, A, transferring data from acute concussion outside of sports into sports. B, we have to be careful transferring data from or knowledge from different types of sports in different parts of the world to other types of sports, because situations are very often sport specific and are unique. And then if you look into the situation that we're dealing with, it might be different from the data that we base our decisions upon. And then you have to adopt what you're doing, because the data may not be able to drive your decision. And especially when we're talking about concussion, because that is also something that I often explain. In a concussion, it's not like an ACL tear or an twisted ankle or something else. In concussion, several things play a role. The individual predisposition may play a bigger role than we think. And also the situation in which the biomechanical forces are applied may play a situation. Everybody who sees concussion in clinic can attest to that, because if the same biomechanical force is applied in an accident at home, in a motor vehicle accident, in a work-related accident, or on a pitch or in a different type of sports stadium, there might be different implications. And this is something that needs to be considered, and that makes it so challenging to come up with easy and unified guidelines.
Okay, got it. So there is evidence, but it's a bit diversified. Edwin, you wanted to react?
Yeah, well, a few things. I think you asked me what would you for the first initial moments, the 90 seconds or perhaps the 60 seconds. Of course, when you enter the pitch, you already have some things in your mind, about neck injury. Is somebody unconscious? Loss of consciousness is only in 10-15%, so it's not regularly. But if it happens, for sure it's a concussion, so he gets to get off. But there's also something like education to players. That they don't start moving the player while he's still concussed or while he's unconscious, but also not trying when he has some kind of a tonic gesture of his jaws, that they want to open his jaws, because otherwise he could swallow his tongue, which is anatomically impossible. Those few issues, you could prevent on forehand by proper education. And I totally agree with Claus. You have perhaps only one concussion per season you have to deal with, but still, one of the things that makes it difficult and is different than the concussions the doctors see in hospital, you see them immediately. and you see them on the pitch, and probably they will be the lighter versions that will never go to hospital. So you have to deal with these kinds of concussions as well. Very subtle changes, and you have to discover them. That makes it very challenging, and you need some kind of a support with it. But it's good to know that if you have several questions that you have in your mind, you have to check the neck, for example, but also what are the most prominent symptoms and signs that people have when they have a concussion, even when it's subtle, that you should be aware of. And you have, as soon as you approach the player, you have it in your mind, or supported on the cards of the user that is developing, because it's not, like Claus said, something that's in your routine. You don't do it regularly, but still you have to pose yourself a few questions, and pose those questions also to the player. Is he still conscious? And by the way, also that's different for example, by a neurologist, and also, which I think is I'm a little bit unhappy, but I don't know, Claus, how you think, but with the new definitions, that it's still with light traumatic head injury, and concussion is more or less a little bit left behind us as a term, but still I think the criteria for a light traumatic head injury are still pretty much extreme for a light concussion that we have to deal with on the pitch. So, for example, a few seconds or 10-20 seconds of loss of consciousness is not a big deal for me. It's different when it's 5 minutes, but you see it often. Those players, they come the next morning into your medical room and say, "Hey doc, I'm recovered completely." So the loss of consciousness from that perspective is not a serious one. If it takes more than 5 minutes, perhaps it's a different situation. And these are also aspects you have to take into account.
So it's a bit of a tired checklist in your mind. Okay.
Yeah.
Yeah. We let's go to that in a second. I want to focus on this question that's in the chat. It's more about the prophylaxis. So it's from Franz Krulshuber. That's the best way I can pronounce that. I'm very, very sorry. The question is if there's a significant difference when we want to prevent head-to-ball or head-to-head contacts and the outcomes of it. It's a different impact, different ways to take care of this. Can you reflect on that one?
Yeah, I would. I mean, this is in terms of outcome and prophylaxis. I assume that this is a question towards acute concussion. And Evert, you mentioned that already, that the head-to-ball contact in male football is rather rarely a situation that leads to a clinical concussion, with the exception if there's an involuntary head-to-ball contact, which is not a header, which is a completely different situation. However, in female football players, this is the leading situation for concussions, the head-to-ball contact. And work of Kerry Peak and others have shown us that there might be some things that can be approached. So, for example, if females tend to head the ball with closed eyes rather than open eyes, which is what male players more often do. So this is a teachable moment. This is something that can be taught and potentially contribute to prevention of further injuries. So heading technique, Evert said that as well, and I think Edwin, you said that a bad header is always has different biomechanical impact on the head and more unfavorable biomechanical impact on the head than a good header. So let's teach everybody to do good headers instead of bad headers to reduce the unfavorable biomechanics on the head. And then when it comes to head-to-head collisions, there are there are certain situations that are prone to head-to-head collisions. We are at the UEFA level. We're currently looking into the situation of header duels, for example, where one player comes too late but still tries to head the ball, and then heads, for example, the head of the opponent who just headed the ball. So this type of head-to-head collision, when one player is already too late, and yet you have that collision and that impact, in the literature and also in our database, seems to be more prone to cause a clinically relevant concussion than others. And this also gives us a possibility to look into potential mechanisms of how to prevent these things.
Yeah, there's a follow-up question in the chat on that one, Claus, and maybe Edwin, you can start answering this. If there's different consequences or outcomes depending on where the contact occurs. It's from Zacharias Floyd.
Yeah, well, I think one of the aspects that we have to notice is that when you are aware of the context, or you see it coming, you can brace your neck. And I think that the rotational, the unexpected movements in your head and neck, they are give you more prone for a concussion. So if you can brace it properly, then you have no problem. It's why if you leave your eyes open like most males do, then it's obvious that you have more control. When the ball hit you from the back, or perhaps the head-to-head is from your back, and you cannot see it, you cannot anticipate on it either, and it makes you more prone for a concussion. I think that's one of the explanations. And where it is, I don't think that it's so easy. We've seen a lot of football players, also from an amateur level, in our concussion clinics, which we have now for 8 years, and we ask them also to mention where they are being hit. With the ball or head to head, what's the position, and to see if there's a relationship with the complaints they've got. Absolutely not. So where you've been hit is not so prognostic for what complaints you've got, or which part of the brain is affected. I think it's more or less something general, and the individual aspects play a bigger role than the impact exactly.
If I can add to that, that's a great question, because there's what you just saw and what you described clinically, Edwin, is caused by the pathophysiology that we understood is the underlying pathophysiology of a concussion, which has nothing to do with the local impact. We always believe that there's a coup contra coup where the impact occurs and then on the other side, but this is not the mechanism that leads to a concussion. It's more of a diffuse mechanism. I always compare it to a tree. When you hit the stem of a tree, the tree doesn't go back and forth, but inside the tree you see shakes. And these shakes are happening, the diffuse shaking is happening in the brain. And these diffuse shakes affect the axonal networks, the millions of axons that we have in the brain. They're shaken up. And this diffuse axonal injury is more or less unpredictable which type of axons and which type of networks it affects. But the area of networks and the networks that are affected, those will eventually determine the symptoms, and not the anatomical localization of each of those parts, because the networks are the ones that are that are more fragile. And if there's network dysfunction, these network dysfunctions relate to the symptoms and not the localized impact.
Thank you. That was a bit technical, Claus, and quick.
Right.
But okay. No,
but there's data. There's data on this.
Good.
This is actually very well understood.
Yeah. So, but here's the difficulty with concussion, right? It's a clinical diagnosis. There's not a bone sticking out on the pitch that you can immediately act upon. So you still need to make that initial potential decision, for which FIFA is developing the focus protocol at the moment, or it has been developed, and they're validating it. And we have our own on-pitch concussion cards developed that kind of ask the similar things in the initial decision based on a different philosophy. So probably more on that later in this year, when these two approaches are more synergized and that validity has been done. But the consequences is where the questions in the chat currently come in. So I think it's more the clinical side of the decisions we make on the pitch and afterwards. So there's another question on, once the concussed player is removed from field of play, and then if he or she falls asleep, what should we do? This is how I was taught when I was young, right? You shouldn't sleep after you've been diagnosed with a concussion.
So here we need to be a little bit more specific here, because does the player have a concussion or a more severe type of traumatic brain injury? Concussion.
So how do we assess that, Claus? How do we assess whether a player is concussed?
Okay. So if concussion is the mildest form of a mild traumatic brain injury, which is incredibly difficult to determine on pitch or even off pitch. This is something that you will see afterwards, and this is something where if any of the red flags, the so-called red flags, with if you have a tonic posturing or a seizure, or if you have loss of consciousness for a prolonged time, well, this should make you a little bit more careful, because only 10% of concussions are, for example, associated with loss of consciousness. Whereas if you have a more severe type of traumatic brain injury, that might be associated with a little bit of a hemorrhage or an epidural even, or other types of hemorrhages. No, then you wouldn't want the player to fall asleep. But if you're entirely sure that this is not the case and this is a concussion, and this is something that typically is done in the emergency room, for example, where you determine, do you need imaging? And there are clear indications when to do imaging and when imaging is mandatory and when it's not mandatory, but you can still do it or don't do it in the acute situation. So if you more or less rule out that this is a more severe type of traumatic brain injury because none of the red flags are present, and your clinical exam, neurological, neuropsychological is entirely normal, then there's no reason why the player shouldn't fall asleep because they're tired and sleep is actually a little bit helpful. But if you're not sure that this is the case, then if you're not sure that this is indeed the case, then you have to be careful, and you have to not only prevent them from falling asleep, but you have to clinically assess them, which is much, much more important than just prevent them from falling asleep. Because the reason you don't want them to sleep in this situation is because you think they may become unconscious because of a growing hemorrhage inside the brain. So it's not the sleep per se. It's why they deteriorate and why they become somnolent or even comatose. But this is only the case when you cannot rule out a high degree of traumatic brain injury.
Yeah, and Claus, isn't it also the case that the sleeping center is also in the brain, and that sleep disturbances come, they appear regularly. So it might be a case. I suppose this is a question for somebody somebody falls asleep already in the dressing room. So he's been taken off the pitch, and falling asleep means he's still able to wake up and react properly, or perhaps at least in some way of a concussed way that can also, he still can be disorientated or had some short-term memory disturbances. But still, you don't have the alarm signs of something like an serious brain injury, then still it's okay. Let him sleep, I would say.
Again, if you finish your diagnosis, if you have established a clear diagnosis, then sleep is actually one of the three most important pieces of treatment.
Okay.
But the right sleep.
Hey, let's move on in topics a little bit. We're already talking for over 40 minutes, and like I said, I think we can talk much longer about any of these topics. So we chose it a bit broad to show everything we're doing. So the specifics may follow in a follow-up webinar, but maybe briefly, I want to touch upon the concussion charter. Zoran already talked about it a little bit in the beginning, and the consequences given to a club and a coach for not following the concussion charter. For those who haven't engaged with it in detail, Claus, probably, or Edwin, probably you can tell us a little bit more about what's in the concussion chart and what that means for you as a doctor on the pitch.
Well, I think in the concussion charter, the main thing, of course, is that everybody who's involved in match play, so it's the coaches, but also the doctors, the medical staff, they have underwritten more or less the policy that they should protect the player with a concussion, and that the doctor is the one who is in charge when it comes to substitution and nobody else. And that's more or less the basis of this charter. Mm-hmm. Am I right, Claus?
I think that's one of the core values of the charter, but the charter starts even earlier. The charter starts with the necessity to do baseline testing, the necessity to perform education, teaching, interventions inside your organization, to practice the recognize and remove principle, and this is to be done by the physician, and also to follow the return to play protocol, to adhere to the return to play in the treatment, and if the gradual recovery of a player. But as you said, I think it's really amazing that this is a document that is not only signed by the physician and says, yeah, I'm responsible, but also by the coach who says, yeah, the physician is responsible, and also by the CEO, the manager of the team or the association to say, yeah, we recognize, we take care of this. And I can just share a couple of experiences that we made in Germany, where for example, when we implemented baseline testing, we started conversations, and that's also a big strength of implementing mandatory baseline testing, people start asking questions, players start asking questions, and then you can relate the right the correct information to players, to staff, and this was actually wonderful. And the most wonderful part of implementing the baseline testing were the conversations that came, because people were sensitized, people became curious, and much more educated.
Thanks for that addition, Claus. I basically wanted to focus a little bit on the medical independence, because I think that's one of the core elements of the whole charter. So maybe Edwin, back to you again, right? It sounds straightforward, but in practice, club doctors, national team doctors, it's really difficult to maintain. So how would you support your colleagues who are under pressure from a coach or a sporting director to make decisions that go against your best?
And it's still necessary, to have those conversations, unfortunately. But it's what I do is there are two aspects on it. First, explain a new coach you have to work with that you're responsible on two aspects. It's the heart and the head, and nobody can interfere with that, because it's serious business and it should be done by you. That's one step. So you have to explain it on forehand, so you don't get discussions on the bench, or during the match. Another thing is that you need the backup from your board. So whether it's a technical director or the general, the CEO, they have to back you up in advance, that if there might be a discussion anyway, that they support you as a medical doctor, that you make the decision. So this is perhaps not so frequently occurring, but if it occurs, you have to be backed up, and you have to arrange and organize it in advance. Because if you do it later, then you always come in discussions on moments you don't want it, not during a match and those kind of stuff. So you have to do it immediately, immediately when you have a new coach, and that's part of it. And I think that's the most important thing. And stick to your opinion. And I know, under pressure, everybody's going to soften a little bit, and perhaps support decisions that you would never thought you would do so when there was no pressure on you. So you have to be aware of it, but keep yourself strict on these issues when it comes to the heart and the head.
That's good advice, Edwin. Thank you. There's one more question on this specific topic on the on-pitch work from Connor Wright from England, who says they typically use the FA concussion guidelines to assist, whether we have our own published guidelines. We just alluded already that FIFA is also working on an on-pitch assessment tool. Yes, we have one at UEFA. We can briefly show it here on the screen. So this is the first page of our on-pitch checklist. And, if you squint your eyes, all these checklists that are available follow a similar, if you ask me, follow a similar line of thinking. They're all just a little bit different. So I do think that in the near future, we need to see how we can streamline these so that at least they follow the same process and the same checks. But yes, they are available. So ours, you can find them on our LinkedIn group, for instance, and the FIFA ones are also findable if you look for the focus protocol, and the FA has its own. So just wanted to answer that, Connor. I hope this is enough. Last topic of today is brain health for the retired player, long-term brain health for the older player, you name it. There has been a question already in the chat on that earlier. So let's go to that one from Mariana. Yes. Whether there are any procedures that we follow for preventing concussion-related symptoms later in a career. And I think that's exactly where we wanted to go with this last little section. So Claus, maybe you can introduce your thoughts on this with the long-term brain health.
Again, great topic. Circling back to what is concussion-related dementia. that's really, really difficult to define, to identify, and of course to treat, because prevention is the best. And by the way, the best prevention is detect every concussion and treat every concussion accordingly. Because most of the dementia cases that you see that where you think they might be related to concussion, or for example, if we look into the sports of rugby or American football and we see CTE, CTE is probably not an effect of concussion. CTE is probably related to repetitive head impact at a very, very high level and very much impact. But there's still much, much more data to come on this topic as well. And this cannot be related to football. This cannot be transferred to football without further discussion. But if we look into the literature clearly tells us, well, do we need to take care of our football veteran players? Yes. Do they live longer? Yes. Do they have, is in this group, is there a little bit of an increased risk for not only dementia, but other types of neurodegeneration? Possibly, because if you look into different studies, you get different reports and you get different data depending on the cohort you look at and the method that you apply. But if you look into dementia research and try to link that with the data that we get from sports, so for example, I would encourage everybody to read the Livingston report from the Lancet Commission on Dementia. They have identified 14 potentially modifiable risk factors that account for 45% of all the dementias in this world, not only Alzheimer's, but also other type of dementias. And number 1 and number 2 are being hard of hearing and having high cholesterol. And these account for 7% in this model of this 45%. Traumatic brain injury is one of them, but as I said, it's not entirely sure what part of traumatic brain injury contributes here, whether it's a severe traumatic brain injury, which is worse than concussion, or the repetitive head impacts. And then the other thing that is still debated is how are the interactions between any of those exposures to toxins like alcohol, like smoking, like nicotine and everything, and the individual predisposition for a potentially more difficult and worse outcome after a head injury. So does that make you even more prone? These are things that we understand from the animal model, because animals are more prone to longer consequences of concussion if they are exposed to these other stimuli as well. But we don't know whether we can relate that to the human world. What we can do to actively prevent concussion, to actively prevent dementia, is focusing, for example, on these potentially modifiable risk factors, because they will most likely be efficacious not only in athletes, but not only in the general population, but also in athletes.
Can I ask you a devil's advocate question there, Claus? Because you talk about you're talking about modifiable risk factors, right? So I then wonder, what does that look like? Because if you tell a 55-year-old former professional footballer to exercise more and sleep better, that's in itself not really a useful intervention to convey, right? How do you see that works in practice?
You can, but this is what my clinic looks like very regularly, because what it looks like is find an individual pattern, find an individual approach, identify the individual risk factors that are most prominent in this individual. And the other thing that I always tell my veteran athletes is there's not a thing that you can change looking back, but there are a bunch of things that you can change looking forward. So you can still work the numbers in your favor if you're looking forward. So for example, there's just been a study 4 or 5 weeks ago that was published that showed that not only if you're hard of hearing, it's not only a risk factor, but if you actually if you're treated by wearing a hearing aid, you decrease your risk of becoming demented. So it's the intervention actually works as well. It's not only the risk factors. So you work on all these, you identify the risk factors. So is sleep an issue in this athlete? Well, then it needs to be fixed. But if it's not an issue, it doesn't need to be fixed. And this is something that could be that is very, very often done by patients themselves. So if you look at your veterans and if you counsel them appropriately, there's a lot of things that they can do on your own without you telling them anything.
Okay, and that's for the long term, and on the short term, I think avoiding that somebody gets repetitive concussions, because that's also awkward. Perhaps you might be a little bit too fast in having your players bring on the pitch again and make them, from that perspective, more vulnerable. Because if you go too soon, it might be that the brain is still vulnerable and that you're more prone for another concussion.
So we can already start, early.
At least follow the protocols that are there. And it might be that some people might even take longer than the 1 week. We usually have in our minds. Perhaps it might be 2 or 3 or 4 weeks even. And be honest about it. And also, the player has to be honest about it.
And Edwin, are current players concerned about this? And is there any advice you give them at this very moment?
Well, it depends a little bit, but it's usually they're not that concerned. I think that there are a few that, for example, the strikers, the target men, or the central defenders who will head a lot, they have perhaps more questions, but still they continue playing and they don't have so many questions about it. So I think we might be perhaps it's good because it makes a relief, and too much concern isn't good either. That's one of the issues, I think, about concussions. It's good that we are worried about it and that we want to take good care. But if everybody is scared and when somebody is concussed, and most of them, they go within a week without any problems, they will solve. It's more than 90% of it. But if you make people scared because they have a concussion, then probably they will have longer complaints and also different complaints, not because of the concussion, but because of the fear they've got. So, also for children, those kids with very scary and careful parents have more symptoms and they have longer symptoms. So the environment also decides or what kind of complaints and how long you've got it. So please, we have to take good care, but don't exaggerate it. That's one thing in advance. But you have to be certain about the complaints that somebody still has. And don't stay so fixed on the protocols, but individualize it. Not everybody's the same. If you've seen one concussion, you've seen one concussion.
Edwin, your opinion is actually backed up by data. There's good data that shows that if you're anxious, if you have a longer recovery and a more unfavorable outcome.
Yeah. So that's already kind of the take-home messages, right? I'm gonna ask Zoran to come back on the screen because there has been two questions on education out of UEFA, and Zoran, I think you're better attuned to answer these for us. So the first one is whether we should organize meetings with technical medical staff on such important matters, and this question came in when we talked about the charter. So I guess this reflects a little bit on that. Maybe Zoran.
And as I have already anticipated the second question, so it's about the communication, same issue but the different wording. It's about the communication with with coaches and so on. So one, the integral part of the concussion is the fact that we need to education. It's an integral part of the concussion charter. Also, it has to be signed by the head coach, by the CEO of the club, and by the doctor. So that's already communication. They should read what they're signing. And obviously, we supported this by regulation. So I'm sure now that when we publish this, they will start reading it. That's one. Two, regarding education, we included this in the education of the coaches. So medical education, first aid, concussion, but not only this, nutrition, mental health, and also anti-doping is part of the education for the license of every license in UEFA. So we made it sure as of, I think, a year ago, it's a mandatory part of education. And finally, you're right, communication is not just horizontal between us doctors. It's not vertical only between us and the players, but it also has to go in all directions. So we in UEFA are talking to referees, we are talking to the delegates, we are talking to the agents of the players. And if you do educational sessions, very important for the players after 30 years on the bench, include their family members, most importantly their wives, who are very often making decisions. But I can only back up what Edwin says. Do not exaggerate. It's our responsibility to send reasonable information, because sending a message that our sport is dangerous is the wrong message. Our sport is healthy. Football players live 6.5 years longer. Overall quality of life of the football players is better. They have less cardiovascular diseases. They have less malignancies. I have no clue where does it come from. But on a Swedish UEFA study, we see they have less malignancies. So you cannot look at it from one side. Obviously, we have a responsibility to prevent the damage, but also about the message that we are sending. So yes, there is plenty of communication going in all directions from our unit. And then we are coming out with these infographics. Please find them at our LinkedIn page that are designed for you to share it with your coaches, players, everybody, because they're really designed with the normal standard English, not the medical one.
That's a perfect outro, Zoran. So I don't have to do that anymore. So all there's left for me to say, we're already a little bit over time, is that we will continue our journey in the next medical webinar on the 25th of May, which is 1 week before the Men's Champions League final and the Monday after the Women's Champions League final. But we will focus specifically on the finals and give you a little bit of a sneak peek behind the scenes of how it goes in the medical staff and the medical preparations of such events. Also, don't forget to mark your calendars for the UEFA Medical Symposium on February 2 to 4, 2027, where we also have concussion and brain health as a feature prominently. So thank you for joining us, for all your questions and for the care you provide for footballers at any level. From us at UEFA, have a very good evening, day, afternoon, wherever you are in the world, and we look forward to seeing you next time. Thank you all.